Welcome to my oral presentation for SOCH 311 Foundations of Public Health, Part B. My name is Molly Addison and my student number is 237741. Firstly, the project name or public health initiative is called Exercise as an Essential Treatment Method for Women Experiencing PMDD. PMDD, also known as premenstrual dysphoric disorder, is a complex and chronic health condition that affects about 3 to 8% of women of menstruating age and can commence the moment we start to bleed. Women with PMDD experience moderate to severe cognitive, psychological, behavioral, and somatic symptoms that occur in response to the hormonal changes in a woman's menstrual cycle. PMDD commences during the luteal phase of the menstrual cycle and can often last up to 2 weeks, with cessation of symptoms soon after menstruation. If the symptoms persist upon menstruation, then the diagnosis of PMDD is ruled out. The fluctuations of sex hormones, estrogen and progesterone, produce symptoms including, but not limited to, either singularly or concurrently, debilitating anxiety, severe depression, feelings of crippling overwhelm, disordered sleep, such as constant sleep, hypersomnia or insomnia, the ability to fall asleep, brain fog and poor focus, in addition to unshakable lethargy, breast tenderness or swelling, weight gain, joint and muscle pain, mood swings accompanied by a sudden onset of sadness and tearfulness, increased sensitivity to rejection, and even a chance of psychosis. If untreated, these symptoms can manifest into suicidal ideations and suicide. The gravity of these symptoms impacts one's quality of life and can have a ripple effect on one's ability to work, their academic performance, social life, romantic relationships, familial relationships, and their relationship to self, which becomes an immediate public health concern. And despite falling under the branch of mental health, due to the smaller percentile of PMD sufferers nationally, there remains limited awareness and understanding of the disorder within the medical community. Many people are unaware that this exists and often confuse it as just PMS or symptoms leading up to the bleed. Awareness, however, is imperative from a public health perspective. In 2019 to 2020, the expenditure on mental health services cost Australia around about $11 billion or $431 per person annually. However, despite the increase in spend, treatments and services are not meeting the community expectations or curbing the rise in mental illness. Thus, we need to look at alternate ways of treating this disorder. Currently, to be diagnosed with PMDD, the DSM-5, the Diagnostic Statistical Manual of Mental Disorders, requires the patient to meet the following criteria. Symptoms must be confirmed via a daily prospective daily ratings scale for a minimum of 2 menstrual cycles, in addition to the presence of these symptoms in most cycles from the previous year. To obtain a diagnosis, the healthcare professional must first rule out alternate possibilities such as chronic fatigue, anemia, fibromyalgia, migraine disorder, PMS, or premenstrual exacerbation, also known as PME. However, again, due to the lack of training in the medical and mental health facility, diagnosis and commencement of treatment can often require a significant investment of time and money and may require seeing a specialized professional such as a gynecologist or psychiatrist. This can cost the patient around $200 out of pocket, which can be another added stress for the PMD sufferer. The symptoms of PMD can impact one's ability to work, and therefore the budget would be lower. Furthermore, as research and understanding develop, the complexity between differentiating the disorder as a physical or mental condition plays a fundamental role in ensuring that women with PMDD access the most appropriate treatments. In 2019, there was a significant step forward when the World Health Organization classified PMDD as a disease of the genitory system rather than as a psychiatric condition. So now it can be classified as both or either. The mainstream model of treatment suggests pharmacotherapy as first-line treatment. However, these treatments, such as SSRIs, which are often used as a prophylactic to subdue symptoms, or in an intermittent dose to subdue symptoms during the luteal phase, are met with a lot of side effects. These side effects open up the discussion for alternate treatment options. Side effects of SSRIs include nausea, headaches, cognitive disruption, poor memory and focus, sexual dysfunction, insomnia, and weight gain, which is a known risk factor for PMDD. Other first-line treatments are hormonal contraceptives such as the OCP, which are again have similar side effects as SSRIs, and then psychotherapy, cognitive behavioral therapy, which can be suggested as a singular form of treatment or in conjunction with SSRIs. The final stage of treatment is suggested that the woman has a hysterectomy, which is the removal of her uterus, or a BSO, which is the removal of one of a woman's ovaries and fallopian tubes. Both invasive surgeries result in permanent premature menopause, and risks include vaginal dryness, urinary incontinence, decreased libido, heart disease, and bone loss, which can cause a myriad of other health concerns for a woman's body, and especially if this is done at a young age, say in their 20s and 30s, there are lifelong repercussions that follow. Due to the need for alternate treatment with minimum to no adverse effects, this proposed health initiative invites any woman in the Northern Rivers, Australia, New South Wales, who meets the criteria of PMDD to participate in active daily movement practices or an exercise class. A minimum requirement of 20 minutes over 8 weeks, with the lifelong hope of continuation to modulate symptoms during the luteal phase, in addition to general well-being support. So why exercise? Exercise is well indicated for PMDD due to its multifactorial benefits on a person as a whole. First, exercise improves symptoms of PMDD by elevating beta endorphins, neuropeptides involved in pain management, which possess morphine-like effects. Thus, it reduces experienced pain in the sufferer. Secondly, exercise regulates the progesterone and estrogen levels by stimulating the release of a sex hormone binding globulin, which binds to the free estrogen in the serum. Excess estrogen can cause a myriad of adverse effects and symptoms that we see in PMDD. Thus, adequate levels of estrogen and progesterone are essential for homeostasis. Thirdly, exercise encourages the production of endogenous anti-inflammatory chemicals and potentiates social interaction through team sports and local exercise centers. This adds another layer of medicine, as community and a sense of belonging creates wellness for a person and an individual. The program will be organised and delivered in community centres, yoga studios and surf camps, and promoted through various media channels. Traditional marketing of this public health initiative will run via advertising. Posters and flyers will be printed and hung in local centres and popular hubs such as coffee shops and eateries in Northern Rivers, New South Wales, Australia. As this is a pilot initiative, gaining as much exposure as possible will be essential for recruiting PMD participants over 8 weeks. Radio advertisements will commence 1 month prior to the start date and play on the local radio during peak listening hours. The rationale for traditional forms of marketing drives the educational focus on the benefits of exercise. Not only is it a beneficial lifestyle choice, but an empowering tool for self-management of symptoms in an easy, digestible format. Often exercise or movement practices can be skipped due to being time poor. To avoid skipping the classes and increase compliance, flyers and posters will encourage self-motivated exercise, which can be performed at any time of the day. Thus, scheduled classes, which will also be held in community centres, will act as an offering and encourage the healing power of community, but a daily attendance is not considered essential for participants.